for just a short period of time here. I did on the review. When you look at this, now in Isidore, there's a little thing under the course materials that says study exam tips for exam 3 or something like that. If you click on that, I have it divided into different sections and chapters, but peripheral nervous system, it tells you exactly which. There's a couple tables in that chapter that is the ones you want to pay most attention to, and then whatever we talk about right now. So it highlights that for you. So what do we mean by the peripheral nervous system? It's all neural structures distal to the spinal nerves. Okay, so once you get out of those dorsal roots, and then they comes the spinal nerve and out. Everything from that spinal nerve out is peripheral nervous system, is kind of what we're talking about here. And these are just a parallel bundles of axons in these peripheral nerves. There's, they contain sensory, motor, autonomic, and they're contained within 3 compartments, 3 connective tissue sheaths. You have an endoneurium, a little sheath or a little surrounding that's around each individual axon, has its own little sheath. And then you've got a perineurium that goes around a bundle of axons, okay? And then you've got an epineurium around the entire nerve trunk, okay? And that's showing you this picture here. This is a good picture from Crossman here. So the endoneurium is this little tiny black layer here that you really can't hardly see. It's microscopic. Along individual axons is the endoneurium, okay? And this is the myelin sheath, but there's an endoneurium right on top of that myelin sheath, and also right on top of the axons is the endoneurium. Then you have the perineurium, which is this yellow that encapsulates whatever number of axons that are in there. That's the perineurium. And then you have finally this whole area that's around all of those, the entire nerve trunk, is the epineurium. Okay. And as long as you have one of those intact, there's a better chance that you can get regrowth, because it provides like a tunnel or a pathway for these things to regrow. And Dr. Merriman actually found something. Somebody has come up with a really neat like nanotube scaffolding now where they can simulate the epineurium of a nerve, and they can bridge huge gaps in nerves and allow them to regrow with almost normal function. They've done it in mice now, and I think some primates, that they have high hopes that it can work for humans too. So that's the big thing, is joining up nerves. Once they've been completely severed and are too far apart, you can sew them back together, and you get some regrowth and some function back, and it sometimes can be okay, but it's always kind of iffy. But if you have a tube and allow them to grow together that way, you're going to get better connections in those things, because you don't have as much of the scarring and so forth. This is one of the tables, although it's in yours, it's a different number, I forget. This is from an old version. This is from like version 3, but the table hasn't changed. This is stuff you already know. This is actually just review for you guys. So, this is the axon as far as describing it, anatomically what it looks like. It's larger myelinated or medium myelinated, small myelinated or unmyelinated. Its typical conduction speeds, its diameter. You don't need to know exact diameter. You just need to know one's larger than, more large, medium, small. Don't need to know the exact diameters. For efferent axons, okay, these are the classifications for efferent axons. We've talked about A alphas, right? Those are the axon types that go to the extrafusal muscle fibers. And we've talked about A gammas. A gammas are the ones that go to the interfusal muscle spindle fibers. That's the classification of those axons. We have not talked about, there's a B for an efferent axon that goes to, that's the presynaptic autonomic neurons. Okay, the presynaptic autonomic neurons for both your sympathetic and parasympathetic, those axons are classified as B axons. Okay, and then there also is a C axon for your postsynaptic autonomic neuron. So there's a C afferent axon, there's a C efferent axon. Okay, they're both, unmyelinated, slower conducting. Okay, so your autonomic nervous system is a little slow to react. It's not like instantaneous. It takes a little bit. I mean, we're talking seconds, you know, versus milliseconds. You know, these you already know, the 1As, 1Bs, and 2s. These are the muscle spindles, GTOs, touch and pressure receptors. Those are carrying those on those larger myelinated, fast axons. Then we have the A delta fibers, which are associated with fast pain and temperature, and nociceptors in the viscera, okay, fast muscle fibers. Types of peripheral nerve disorders, we can have mononeuropathies, which means an individual peripheral nerve is having a problem, just a single peripheral nerve, like a median, like an ulnar. Okay, or peripheral branch of that. You could have a branch of the median nerve that's damaged. That would still be considered a mononeuropathy. You're only affecting one nerve. There's this thing called multiple mononeuropathies. Some people with diabetes present with multiple mononeuropathy, but it's more common with diabetes to have what we call polyneuropathy. This is where you have multiple individual nerves that are involved that don't necessarily work in this symmetrical proximal distal kind of thing. They might have bilateral, some people with certain disorders have bilateral carpal tunnel syndrome. You could have, if you had bilateral carpal tunnels, that's a multiple mononeuropathies. If you have bilateral, or some people have inflammation of blood vessels, I forget the exact name of it now, where the blood vessels that are around certain nerves, there's inflammation of those and they don't get proper nutrition, and you can have nerve pain and neuropathy associated with these random areas that have impacted the blood flow via this inflammatory blood vessel disease. And that can cause this multiple, it's much rare to see multiple mononeuropathies. It's just, the most commonly somebody has bilateral carpal tunnel syndrome. Somebody's doing a repetitive job on a factory line or something and gets, you know, bilateral carpal tunnel. That would be a form of multiple mononeuropathies. Radiculopathy is the one you're going to see a ton of, and that's where you have some type of a spinal nerve's been impinged, whether they've got stenosis, they've got arthritis in the little foramina, and it's pushing on a spinal nerve coming out, or they've got a disc bulging into that spinal nerve. Okay, that's a radiculopathy, is a spinal nerve problem. The whole spinal nerve is getting impacted, not that branch of the peripheral nerve at the end. Okay. Then we have polyneuropathies. Polyneuropathies would be things like diabetes, where you're getting multiple nerves distal to proximal, so all the nerves below my knee are being impacted here. That's a polyneuropathy. I'm involving, you know, saphenous nerve, popliteal nerve, you know, all those kind of things, multiple polyneuropathy. Guillain-Barré is a form of a polyneuropathy. It's affecting those anterior nerve roots and affecting multiple nerves, polyneuropathy. Okay. And then this is a table you should just kind of, I think it does a good job of kind of showing you what happens with nerve injury, and there's a classification system, and based on where you fall in that classification system, it predicts your recovery. Okay? And this is something for you that's important from a clinical standpoint, because you have a patient who comes in and they've got a peripheral nerve injury, and if the physician's provided you a classification for that, or if you understand the mechanisms of their injury, you might be able to kind of guess what their classification of injury, and then you may be able to predict whether this patient is likely to recover or not, and how long it might take to recover. So if you're trying to provide them time frames, or you're writing your goals for this patient, what those are going to be. So there's a Sunderland classification for nerve injuries, which is a 6-item classification system. And then there's a Seddon classification, which is a 3-level classification system that has nomenclature to it, these names. And so sometimes it's nice to know the name, because it makes sense sometimes when the name helps you understand what's going on here. But it doesn't give you a lot of divisions here or subclassifications to kind of understand the different levels of severity. So I think it's good to be aware of both. So Sunderland classification 1, which is also called a neuropraxia, just some kind of limitation or effect of the nerve. A neuropraxia is only the axonal myelin is disrupted. This would cause a myelinopathy. This could be also a myelinopathy. So a neuropraxia is the same thing as a myelinopathy. Just the myelin is damaged. Okay, so the axonal myelin is disrupted. Depending on how bad that myelin is disrupted, it could take just a day or two for that to recover, or sometimes it can recover, well, yeah, it could be a couple days. Sometimes you can just temporarily disrupt blood flow, when you're sitting there and your arm falls asleep. That's a lack of blood supply to the nerve, so the nerve loses function because of lack of blood supply. If you keep laying on that nerve for a long time, there's a term they call Saturday night palsy. It's when you get too drunk and pass out and fall, and you pass out and lay on your arm or your leg in a weird way, and you lay there for 12, 14 hours because you're passed out. You wake up, and then your arm, you can't extend your wrist, or you're walking with a limp because you lay it across your bed frame with the, your common peroneal nerve there or something. You can actually, if you lay there for 12, 14 hours, you can cut the circulation off for so long that some of the myelin dies. And so then it might take you 3 months to recover from your Saturday night palsy. So be careful, guys. And although this happens also in surgery. Sometimes in surgery, when somebody is under anesthesia and they're positioning the patient can't tell you that, hey, there's the edge of the bed is pushing against my leg there. So somebody goes in for back surgery, abdominal surgery, and they come out drop foot. And it's all because their leg was laying over to the side, hitting the edge of the bed rail or whatever in the surgical table, and nobody noticed. And it was a long surgery. It might have been a 6-hour, 12-hour surgery, and then now they have a drop foot. But that'll easily recover, but that might take a few months. Now, if you just block off circulation for 15 minutes, once the circulation is restored, you didn't actually damage the myelin. But if you leave it there too long, you can get some myelin damage. But you never actually twisted it or torqued it or pulled it apart to actually damage axons. Okay, you just so yeah.
One of my undergrad professors said that when she was dissecting for a super long time, she'd get kind of numb in her fingertips. Is it kind of that same type, or is that?
That might be different. Did she wear gloves when she's dissecting, or
Yeah,
she
was
pinching so hard? Well, yeah, she probably disrupted the blood supply to the tips of her finger for so long that her receptors and her nerves just got a little bit desensitized and lack of blood supply. So yeah, so probably, or she has thoracic outlet syndrome, was holding her arm in a weird way and got some kind of a problem there. But so that's neuropraxia. It recovers, but it recovers fully, complete recovery. Axonotmesis. Axonotmesis is axons. Axons are damaged with axonotmesis. And this is where it gets a little murky. It depends on how bad the axons are damaged, which recovery is. So if you're a Sunderland classification 2, you disrupt the myelin and axon, but the endoneurium stays intact. So that layer, the deepest layer around the nerve stays intact. You didn't disrupt the endoneurium, okay? Again, with this, you get complete recovery typically. Occurs in anatomical order from proximal to distal. So if you damage a nerve, as it recovers, the proximal area is going to get better. It's going to take longer for the distal area. The nerve essentially has to grow back, okay, and regrow and start function again more distally. And the time to recover is a function of the rate of axonal regeneration, okay? A Sunderland classification 3 is disruption of myelin, axon, and endoneurium, but the perineurium, that outer perineurium, is still intact, so the nerve trunk is still intact, but you've disrupted the endoneurium and the axon and endoneurium, okay, but the perineurium is still intact. So this may only be incomplete recovery, occurs because disruption of the endoneurium allows some regenerating axons to become misrouted. They may not go right back to the same place. They may actually not fully go back and reinnervate the same area, okay? The rate of recovery occurs at the same rate as a class 2 injury, so it just depends on how bad the lesion is. So we're typically talking, depends how long the nerve is for a lot of this stuff, okay? So I may have a slide that talks about that in a second here. We'll see. Generally, you're going to get about 1 centimeter a month is recovery. If you really messed up a nerve, but you've got some of the endoneurium or perineurium intact, you're going to take about 1 centimeter a month. So you can literally, like if somebody, I had a friend who damaged their common peroneal nerve in a skiing accident, you can measure from there to the motor point in the muscle, and like, oh, that's 7 inches. It's going to be a minimum of 7 months if everything goes perfect. But it might be as much as 12 to 16 months, just depending on the nerve damage, those kind of things. It's hard to predict. There's no way to go in there and know exactly how damaged those axons were. As long as there wasn't a complete severance, but then you don't know until you see how long it takes to recover is really the way it kind of works. Unless you do a biopsy, but if you do a biopsy, you're damaging the nerves. No, you're not going to do a biopsy of that nerve. And then level 4 is disruption of the myelin, the axon, endoneurium, and perineurium, but the epineurium is still intact. That the larger, most outer layer is still intact. Recovery does not occur unless surgical repair is undertaken with this one. So what they actually do is if the nerve is so if it's crushed, pulled, twisted, where you really disrupted the endoneurium and perineurium inside there, and it's just really kind of mushy, the nerve, what they actually have to do is there's going to be too much scar tissue and too much damage. They actually have to cut the end and get 2 clean ends of the nerve and sew them together. But even then, when they sew them together, the recovery is not the best. You're still not perfect unless and so if you don't though do it, then, and a lot of times they don't know, they'll wait, and if you're getting no recovery after a period of time, then you have to decide, is it worth it? What nerve was affected? How much function have you lost? Do we go back in and cut that nerve and reattach it to see if we can get better recovery of it? Okay, but the nerve is still intact. That epineurium is still intact, but they have to go in and cut a little slice out of it and get 2 clean ends and sew them together. Okay. Then a level 5 is where we start to what's called a neurotmesis. A neurotmesis is an actual, so a mesis is like a severing or a disconnection between these. So like an axonotmesis is the axons are actually damaged inside, but they're still within their sheaths. This is a neuronotmesis. The nerve is actually totally disrupted. So complete nerve transection. Recovery does not occur unless, again, surgical repair is undertaken with a neurotmesis. You have to actually, and because you've disrupted and the nerves have been ripped apart and they pull apart, sometimes if they're really damaged, you have to like try to stretch them back together, and the process of pulling them together to sew them up together can also be traumatic to the nerves. So that's why in those little tubes, you can create the scaffolding between them and let them grow on their own. Seems to be better than trying to cut ends. In the sewing process, you also give some trauma to the edge of the nerve, so that's why it's never perfect. But there's some pretty impressive results you see where people like have their whole arm, hand, replaced. And then they're getting decent hand function. It requires incredible effort and rehab. You have to train the hand and move it while those nerves are recovering to make sure they're growing to the right places and getting the neuroplasticity to occur. So it's not like you can just put a hand on somebody and it just gets better on its own. It requires grueling months and years of rehab to get basic opening and closing of the hand and some sense of control there. And then a level 6 is a mixed nerve injury, where you have a combination or degree of nerve injury is present in the same segment of the nerve. Part of the nerve has some axonotmesis, part is neurotmesis, and that's just these, kind of traumatic injuries. You cut by a chainsaw, or you get into a car accident where you get some severance, but also some mashing and and twisting and torquing, and those kind of things can cause this mixed nerve injury. So that's it on peripheral nervous system. Any questions on that?